post-call, and that way people can always catch up later. Okay, please use the chat. Of course, you're welcome to unmute, but we know that that can be challenging in a group this size. But I know that all of our speakers, including Dr. Luks, loves taking questions. So please do put questions in the chat. I will monitor it, and I will make sure that we pause to see those questions. All right, I think that is my preamble for this morning. If there are any questions, burning thoughts, please throw them in the chat. And otherwise, I'll turn it over to Dr. Luks. Thank you so much.
Thanks so much, Gabby, for the introduction and the opportunity to teach again this year. Actually, you talked about this being a longstanding tradition. We did this when I was an intern here in the program 22 years ago. Ken Steinberg actually did one of my lectures during that time. So it's nice to meet everyone virtually, and welcome to the program. And I hope your training's off to a great start so far. Just in terms of disclosures, I don't have any conflicts of interest to report regarding anything we're going to talk about in the next hour. In terms of the objectives for the session, this is actually not a talk about how to read a chest radiograph. That's something you covered a lot in medical school, and it's difficult to cover in a short period of time. Instead, the focus is to go through a whole series of things you need to be able to recognize or distinguish on a chest radiograph. One of the top types of things that are going to bail you out in the middle of a call night or with a difficult patient care situation. So we're going to spend some time talking about how to assess the position of lines and tubes, how to identify pneumothorax and other forms of barotrauma, how to distinguish between a massive effusion and collapse of an entire lung, how to identify less common presentations of pleural effusion, something you'll see often, and then how to identify a couple of other types of causes of chest pain on plain films. Now, before we get into this, some of you, if you've already worked with me before, you'll certainly learn this if you work with me in the MICU, will know that I'm a bit of a stickler about terminology and using the correct terminology when we communicate with patients and in our clinical care. And so there's actually a few terminology peeves that I have applied to interpreting chest films, which I might as well get out of the way now and save you some consternation on my part if you happen to rotate on the ICU service when I'm attending. First is, everyone calls these films chest x-rays, but the reality is you can't actually see an x-ray. It's a beam of energy. What you see is a film or a radiograph, and that's what you're going to interpret. So that's what you should call them. A lot of times when people are referring to the adequacy of the lung volumes in the film, they'll say, well, it was a poor patient effort. Well, quite often it has absolutely nothing to do with the patient's effort. They may be trying really hard. They just can't get up to a high lung volume. As an alternative term, people often usually use the phrase, there was a poor inspiratory result on the film. So we shouldn't use any of those things. Just if you're trying to label the lung volumes on the film, just say the lung volumes are low, normal, or high, they're adequate, they're inadequate, etc. And finally, it's important to note when patients are rotated in a chest radiograph, because it can distort the appearance of structures in the middle of the chest. But a lot of times I see people trying to figure out whether the patient's rotated to the left or rotated to the right. The bottom line, you shouldn't waste any mental energy on that question at all, because it doesn't matter. All you need to know is that the film's rotated, and it's going to distort the way things appear, and you can move on from there without determining which side they're rotated to. So with my few terminology peeves out of the way, let's get started with a case. So you're doing one of your first central lines in residency, and you put a left internal jugular central venous catheter into a 24-year-old female patient with Down syndrome and sepsis. The line goes in smoothly with no problems threading the wire or passing the catheter, and you order a post-procedure chest radiograph, which shows the following. I'll let you take a look at that for a second. So it's a left internal jugular line that you see here. So you look at the film and think about the position of that catheter. And I'll leave the film up on the screen and pose a question to you. So after reviewing the chest film, what should you do next? Should you give approval to the nurse to use the line? Should you draw blood gases off the central venous catheter and the wrist at the same time and compare the results? Should you remove the catheter? Should you consult vascular surgery to remove the catheter? Or should you consult interventional radiology to help you confirm the position of the line? And Gabby's going to put up an audience response question for you, and we'll give you about 30 seconds to put your answer in there.
All right, everyone, go ahead and put in your response. Remember, this is entirely anonymous. So please go ahead and answer. You don't have to think too hard about it because we're going to share the answer in just a minute. All right, I'm going to go ahead and end the poll and share the results here. And Andy, can you see that?
Yeah, I can see the results. Looks like a big
Great.
smattering of results across the spectrum of answers. The correct answer here is actually choice number 2. Before you do anything to remove the line, it's just useful to compare blood gases off the central venous catheter and a radial artery to see if this is a venous or an arterial placement. You're right to consider the fact that this catheter tip sits on the left side of the chest near where the aortic knob is, which raises concern that it's in an artery. But it turns out this patient had a persistent left superior vena cava, congenital anomaly often seen in Down syndrome, and this catheter is in a venous position. And this is one of the ways you could have sorted that out. And I'll talk a little bit more about that later. So the first thing we're going to talk about this morning is how to assess the positioning of the tips of lines and tubes, something you're going to do quite often as an intern and through the remainder of your residency. So when you place a central venous catheter in either the subclavian or the internal jugular position, you want the tip of the catheter to be at what's called the caval atrial junction, where the superior vena cava meets the right atrium. The way you identify that on a well-done film is you identify the right mainstem bronchus. And where the right mainstem bronchus crosses the right heart shadow, that's the typical location of the caval atrial junction. And that's where you're going to want the tip of the line to be. So here's another example I want you to look through, and you can put your answers in the chat. What do you think about the suitability of using this central venous catheter? Safe to use or not safe to use? Okay, it looks like a couple people putting in the chat that they don't think this catheter is safe to use. Well, this film turns out to be a good example of why you want to be systematic when you read chest films, not just look at a single item and take all the information you're seeing in the film into account when you're trying to figure out what to do. Because it turns out that this catheter is safe to use. Even though the tip is sitting on the left side of the chest where you'd worry that it might be an aortic location, this patient has situs inversus. The left hemidiaphragm is actually much higher than the right hemidiaphragm, suggesting maybe the liver is actually under this side. And this patient also has evidence of bronchiectasis. And the combination of these things, which suggests that this patient might have something like Carter-Hainer syndrome, for example, marked by the presence of dextrocardia, everything's flipped to the opposite side. And it turns out that this patient's vena cava is actually on the left side of the chest. So this catheter would in fact be safe to use. Okay. So again, bring all the information at your disposal into a film to help you answer clinical questions. Now, you are going to be stuck in some situations where the line looks like it may not be in an appropriate position. Before you take it out, there's a couple of things you can do. You can draw blood gases simultaneously off the central venous catheter and the radial artery. If the PO2 is markedly different between those two draws, that suggests that the central line that has the lower PO2 is in fact in a venous position rather than an arterial position, whereas if those two blood gases look exactly the same, you probably have an arterial placement. The other thing you can always do is transducive pressure off of the central venous catheter. And if you see an arterial pressure, well, guess what? You've got an arterial placement. But if you've got a much lower venous pressure waveform, then you've got a central venous catheter. And ideally, you're going to be transducing pressures at the time of placement of the catheter so you can avoid any uncertainty as to whether you're in an arterial or venous position.
Andy, before we move on from that film, there is a question in the chat about the location of the aortic knob and whether that might help you.
Yeah, for this patient, the aortic knob is over here. And you're right that it is on the opposite side, but sometimes you can be fooled in films because you'll see the ascending aorta coming up the right side of the chest, and you still see a convexity over here, which could fool people into thinking that the aortic knob is in fact over here. I think anytime catheter tips cross the midline and go to from the right to the left side of the chest always raises some concern that you might have an arterial placement. You should at least think about it in that situation. Now, another tube you're going to have to try to assess the positioning of quite often, probably more often than central venous catheters, are feeding tubes, which get placed quite often in our patients, whether they're on acute care or in the ICU. For the correct positioning of a feeding tube, you want to see the tube come down the midline all the way to the abdomen. It should not break off the midline in the middle of the chest. The tip of the catheter, which is usually identified because it's radio opaque, should be below the diaphragm. The feeding tube is typically going to course around the greater curvature of the stomach, and then you want to see the tip pointing away from the gastroesophageal junction. Being below the diaphragm and tip pointing away from the gastroesophageal junction will decrease the risk of aspiration. Do not spend a lot of time stressing about whether the tip of the tube is in the stomach or the duodenum, because that does not markedly change the risk of aspiration for your patients. Okay? So here is an example of a weighted feeding tube that's been placed in a patient, and you can see the tip there. Do you think this tube is okay to use or not okay to use? You can put your answers in the chat. Good. So I see a lot of people saying that they don't think that this tip is in a safe location. I think that's the right answer in this case. The tip is pointing back towards the gastroesophageal junction, which is going to theoretically increase the risk of aspiration. So you would ask the nurse to try to reposition the catheter tip in this particular situation. So good work on that. Now, when you have patients that are in the ICU and get intubated, one of your tasks post-intubation is to look at where the tip of the endotracheal tube is located. Ideally, what you want to see is that the tip of the tube is below the clavicles or no more than 6 centimeters above the carina. And the reason is a tube that's too high increases the risk of an unplanned extubation, meaning that tube comes out in an unanticipated manner. And then you want to see the tip about 2 to 4 centimeters above the carina. If it's too deep, that increases the risk of a main stem intubation. Now, on ICU films, it can be quite hard sometimes to see a lot of stuff in the middle of the chest. The films are very busy. So one way you can identify where the carina is if you're having difficulty seeing it is to find the aortic knob and draw a line at a 45-degree angle from the left shoulder down through the aortic knob and continue it on to the right hip. And it tends to run right through the carina. The one thing that I will tell you about when you're looking for the carina is getting closer to the film never makes it easier to see. And in fact, getting closer to the radiograph never makes anything easier to see on a film. You actually want to try to get further back if possible. But that tip about using the aortic knob in a 45-degree angle line can be helpful. Okay, so that's a bit about lines and tubes. Before we move on to the next case, let me stop there and see if anyone has any questions, and you can put those in the chat. So Elena's question is, if a central line is in an arterial position, do you call vascular surgery to help take it out? It is often a very good idea to involve the vascular surgeons, because occasionally when a tip is placed inadvertently in an arterial, when a catheter is placed inadvertently in an arterial location, you can create an intimal flap in the vessel. And if you remove the catheter and that intimal flap is just kind of hanging out in the vessel lumen, that increases the risk of thrombus. And the vascular surgeons have some things that they can do in order to decrease the risk of problems. So I think getting them involved is helpful. If all you did was just puncture the artery at the start of the procedure and never even cannulated from that point. You realize it was an arterial puncture. You just come out, hold pressure, try again, or move to another site. They don't need to be called in that situation. But if you went ahead and dilated, cannulated, et cetera, you should get them involved. All right, well, let's move on to our next case. This is a 36-year-old female patient with a history of unprotected intercourse with multiple partners and a history of injection drug use who presents with sudden worsening of dyspnea that's been developing along with a dry cough over a 3-week period. And here you see the chest film. I'll let you take a look at that for a second. I'm going to leave the film up on the screen and we'll post a question, and Gabby's going to open up audience response question for you. So you reviewed the film, and what should you do next? Should you start ceftriaxone and azithromycin? Should you consult the pulmonary service for bronchoscopy? Should you order a CT pulmonary angiogram? Should you administer furosemide, or should you obtain an upright chest film?
All right, everyone, go ahead and get those answers in. And just want to normalize for anyone who feels like these chest films may be challenging. They are. I've seen different versions of this talk for a number of years, and I always learn something. So that is the point. So we appreciate your engagement. All right, we've got a good response rate here. I'm going to go ahead and close the poll.
So the majority of people here did go for the correct answer, which is to order an upright chest film. This patient has risk factors for HIV, history of unprotected intercourse with multiple partners, history of injection drug use, and they're coming in with progressive symptoms, particular dyspnea, and now have developed some chest pain. And one of the noteworthy findings is that this patient has diffuse bilateral opacities. And with risk factors for HIV, hypoxemia, and diffuse bilateral opacities, you'd certainly be thinking about the possibility of pneumocystis pneumonia. And one of the complications of pneumocystis pneumonia is pneumothorax. And so anytime you see someone with risk factors for HIV presenting with pneumothorax, you'd be thinking about a diagnosis of PJP. Now in this film, the clue to pneumothorax is subtle. If you do a systematic read, you see there's this area of lucency in a deep, narrow sulcus in the right side of this patient's chest. This patient's film was taken in the supine position. So when you see this finding in a film that's done with a patient in the supine position, that raises concern for pneumothorax. And the way you would confirm the presence of pneumothorax is repeating the film with the patient in the upright position, or doing chest ultrasound, or maybe doing a chest CT. Okay. So now we're going to talk about how to recognize what I like to refer to as air that should not be where it is. In other words, major forms of barotrauma. The most common form you're going to see is pneumothorax. And some pneumothoraces are quite obvious and others are not. So here on the left side of the screen, you see a very obvious pneumothorax. You have a collapsed lung, densely opacified, and a large area of lucency outside the lung. Now you can contrast that to this film on the right, in which it's a little less obvious, particularly if you're not in a right position for the film or don't have adequate amount of contrast. But if you look closely, there is a more subtle line out here, and you have lung markings out to that line and then lucency on the other side of it. But overall, it's a little harder to spot because you don't have this densely opacified lung like you have here on the left. So sometimes pneumothoraces are not going to be easy to spot. If you are unsure, the things that you can do are do some chest ultrasound at the patient's bedside, or if that does not resolve the question, obtain a non-contrast chest CT. As I mentioned in the case, when patients are in the supine position, sometimes the pneumothorax is going to look different. And that's because the air gets trapped in a different position in the chest when the patient is in the supine position compared to when they're upright. And one of the classic findings you'll see with a pneumothorax in this situation is called the deep sulcus sign. The sulcus is deep, narrow, and lucent compared to the sulcus on the other side. So if you ever see this finding in a patient in the supine position, you're going to think about pneumothorax. You can repeat the film with the patient in the upright position or get the collection of air to change its location and you see a more classic appearance. You can also use chest ultrasound. As I mentioned before, you can also consider using a non-contrast chest CT. If you are doing chest ultrasound, the finding that you're going to be looking for using the vascular probe is something known as lung sliding. So what you do is you have to look in various portions of the chest. I'm not going to go through all the details of this, but you identify this white stripe here, and that's the pleural line, and where the two pleural surfaces are. And you can see as you look at this line, as the movie's going on, it seems to be moving. People often describe this as like ants moving on a log. That finding is called lung sliding. And if you see lung sliding, the pleural surfaces moving relative to each other, that rules out a pneumothorax. If, however, you see a situation like you have here on the right, where you see the pleural line, this bright white line here, but there does not appear to be any movement similar to what you're seeing here on the left, that's the absence of lung sliding. It doesn't confirm the presence of pneumothorax. What it tells you is there's some problem in the pleural space, whether there's pleural thickening from inflammatory tissue, pneumothorax, or pleural effusion. But the presence of lung sliding is useful for ruling out pneumothorax. Okay. Pneumomediastinum is another problem that you'll occasionally see. The most common situation you'll see this is a patient who's being ventilated for severe ARDS in the intensive care unit. And what you're going to see in this situation is air in the middle of the chest, or the mediastinum. What happens, the most common cause, is that air ruptures out of the alveolar space, and rather than going into the pleural space, that air tracks along the bronchovascular bundle to the middle of the chest. Okay? And that's why you see lucency here, as well as here along the side of the heart. Now that air, once it gets into the mediastinum, can easily communicate through tissue planes and get up into the patient's neck. So whereas the soft tissues look nice and homogeneous and white on the left and right side of this patient's chest, if you notice here, there's a lot more darkness or lucency in the neck soft tissues, and that's because of the presence of air in that location. Okay. The other situation which you'll see this besides alveolar rupture in a patient on mechanical ventilation is some sort of injury to the aerodigestive tract. So trauma to the esophagus or trauma to the upper trachea or main stem bronchi. Now, pneumopericardium can look a lot like pneumomediastinum. You're going to see air along the sides of the heart as we did in the previous film. The way you can distinguish pneumopericardium from pneumomediastinum is that often, although not always, the air will not track up through the upper portions of the mediastinum into the soft tissues of the neck and the chest wall. And with pneumomediastinum, you can often see the air extending underneath the heart. So you'll see a rim of lucency in the inferior margin of the heart as you do here. And here you see a nice example of pneumomediastinum on a lateral film. Way less common, pneumopericardium on a lateral film. And I'd say that this finding is way less common than pneumomediastinum or pneumothorax. So what's the problem in this film? You can put your answers in the chat. Okay, excellent. Everyone has identified the fact that this person has pneumoperitoneum. There's lucency underneath this thin linear opacity, which is the diaphragm. So that is highly suggestive of the presence of free air in the abdomen. This usually connotes the presence of an intra-abdominal emergency. There's been perforation of a hollow viscus, whether it's the stomach or the small and large intestines. Be aware that you can sometimes see pneumoperitoneum after a patient has had a percutaneous endoscopic gastrostomy tube placement or following laparoscopic surgery. But in the absence of any of those procedures, the presence of pneumoperitoneum is going to warrant further abdominal imaging and a consult to the surgeons. And one of the things that often confuses people is how to distinguish pneumoperitoneum from air that's in the stomach or the colon. And there's a couple of ways that you can do this. The first is if you have pneumoperitoneum, so air's underneath the diaphragm is actually a pretty thin band of tissue. So the curvilinear opacity you'll see on the upper margin of the lucency is quite thin. If you're dealing with an air bubble in the stomach or the colon, you've got the wall of the stomach up against the diaphragm, or the wall of the colon up against the diaphragm. And as a result, that band of opacity that you see is much thicker. You can appreciate that the thickness here is much greater than the thickness here. And then the other thing that often is helpful is if it's the colon that's stuck up underneath the diaphragm, you can often identify haustra within that area of lucency underneath the diaphragm, which allows you to make the distinction. So we've looked at major forms of barotrauma now. We're going to move on to another case, but I'm going to stop and see if anyone has any questions before we go on. Okay, doesn't look like any are coming in. And again, if questions come up, feel free to put them in the chat. So our next case is a 62-year-old female who's intubated for respiratory failure due to a left lower lobe pneumonia. She had a right subclavian central venous catheter placed after several unsuccessful attempts in the left internal jugular and subclavian positions. 4 hours later, you're called to the bedside due to the sudden worsening of her hypoxemia and an increase in the static, otherwise known as the plateau pressure on the ventilator. Here's her chest radiograph. I'll let you look at that for a second. So the question now is, what should you do next? Should you order a CT scan of the chest? Should you do a thoracentesis on the left? Should you place a chest tube on the left? Should you order chest physiotherapy on the left? Or should you consult the pulmonary service to perform a bronchoscopy?
All right, great job, everyone. Go ahead and get those answers in. Give it another couple of seconds here. Okay, great. I'm going to go ahead and close the poll here. And I'll share the results.
Answers all over the map on that one again. A lot of people wanted to put a chest tube in this patient. The correct answer here is actually to perform chest physiotherapy on the left side, because this patient has collapse of the entire left lung, likely due to obstruction of the main stem bronchus from a lot of mucus that's being produced as a result of her pneumonia. Now, you'd certainly be concerned with all those difficulties trying to place a central venous catheter on the left side, that there could have been a vascular injury causing development of a massive effusion. But as I'll show you, the findings in this film are consistent with collapse rather than a massive effusion or hemothorax on that side. So we're going to talk about how to recognize whole lung collapse and distinguish it from a massive effusion on a chest radiograph. Occasionally, you are going to see a film in a patient in which you have a whiteout of an entire hemithorax, as you see here with another example in this film on the left side of the screen. There's only a couple of things on the differential diagnosis for a whiteout of an entire hemithorax, and that's a massive pleural effusion, whether it's a transudative effusion, a malignant effusion, or a hemothorax, or it's collapse of the entire lung. And fortunately, there are ways that we can distinguish these films, distinguish these diagnoses on the plain film without having to do a lot of further diagnostic stuff. An important principle of collapse is that when the lung collapses or a lobe collapses, everything shifts to take up the space that was previously occupied by the non-collapsed lung. So when you see whole lung collapse, you're going to see the trachea deviate from the midline towards the side of the collapse. The heart, which you should usually see to a limited extent on the patient's right side of the spine, shifts over to the left and is hidden within this dense opacity. And occasionally you see something known as a cutoff sign in the airway, which I'm going to show you an example of in just a second. Now that's in contrast to a massive effusion. When fluid fills up an entire hemithorax, it's going to tend to push everything to the opposite side of the chest. So the trachea may stay on the midline, but if it does deviate, it's going to deviate away from the opacity, as you see in this case. And the heart is either going to remain in its normal position, but if it shifts position, it's going to shift away. And in this case, the heart is too far to the side, the left side of this patient's chest. So those findings would make this consistent with a massive pleural effusion. If you were having trouble distinguishing based on the plain chest radiograph, the next most appropriate thing to do would be a quick bedside ultrasound, which would allow you to easily identify the presence of fluid as opposed to atelectatic lung. Now, an important finding that often helps you identify the presence of whole lung collapse is something known as the airway cutoff sign. Here's a patient's film on the left. This is a coned-in view here on the right of this portion of this film. And you can see trachea comes down and bifurcates at the carina into the right and left mainstem bronchus. And as you follow the left mainstem bronchus, you'll see that there is an abrupt end to the lucency here. So in other words, the airway is cut off. And when you see dense opacification in this airway cutoff sign, that's highly suggestive of something that's in the airway in this location that has caused cessation of airflow into that entire lung. Another finding that helps you distinguish whole lung collapse from a massive effusion. Now, you will often see various types of lobar collapse. I'm not going to get into how you recognize all the various forms of lobar collapse, but there's one important one that's going to, for you to recognize, that's going to come up more commonly than the others, and that is a right upper lobe collapse. And there's several things we can do to identify when the right upper lobe is in fact collapsed due to either an endotracheal tube that's inserted too deeply, as this one is here, or a mass that may be obstructing the takeoff to the right upper lobe. So what are the key findings? Well, the trachea will deviate towards the side of the collapse. Okay, so in this case, it deviates to the patient's right. The minor fissure, which is normally located in this position, if you can see it, shifts upward. So whenever you see opacification in the right upper portion of the chest and a nice clear curvilinear boundary up in this location here, that's highly suggestive of right upper lobe collapse. Okay. All right. Now I'm going to move on to the next case. And there was a question that came up at the end of the last case, just as I started talking. Grant asked, why do you get the deep sulcus sign in a pneumothorax when the patient's in the supine position? And the reason that the deep sulcus sign develops is just that when the patient's in the supine position, the air shifts positioning in the thorax and kind of gets stuck up in the anterior portion of the chest near where the diaphragm meets the lateral chest wall. It's all just kind of due to the shifting in the position of the air as the patient changes positions that is responsible for that. Okay. All right. Any other questions before we move on to our next case? All right. So this case is that of a 55-year-old male who presents with increasing dyspnea and left-sided pleuritic pain one day after he fell off a horse, and a chest radiograph is obtained. So having looked at the film for a little bit, here's a question. What should you do next? Should you start ampicillin sulbactam? Should you order a CT scan of the chest? Should you start chest physiotherapy? Should you do a chest ultrasound? Or should you place an epidural catheter for pain control?
All right, I see answers coming in. Give this a few more seconds.
That one. Those who voted late.
Okay, and there we go. There's
There may have been a late
answer.
rush of answers on choice 4 chest ultrasound. I have a very twitchy mouse on my computer sometimes. So most of you went for the correct answer here, which is in fact chest ultrasound. This patient has a very hazy hemithorax that's quite different than the other side. And it's also the patient's in the supine position. And so when you see a unilateral hazy hemithorax, can still recognize lung markings, and the patient's in the supine position, you should be highly suspicious of the presence of a pleural effusion. Now, the case, like the deep sulcus sign case, nicely demonstrates that one of the key aspects of reading a film is when you start, you have to assess the adequacy of the technique. Are the lung volumes adequate? Are they rotated? Is the penetration good? And you also need to look at the patient's positioning and whether it's an AP or a portable film. Because the fact that the patient's upright as opposed to supine, or supine as opposed to upright, can make a big difference in interpreting some of the findings. And here, this finding in a patient who's in a supine position is highly suggestive of a pleural effusion, and you could confirm that by doing a chest ultrasound. So we're going to talk about how to recognize pleural effusion on a chest radiograph. Now, in general, in a normal film, the lung should extend all the way out to the chest wall. So you should see lung markings that extend out to the chest wall, though they typically taper and get smaller and smaller as you get more laterally in the chest. Here you see an example of a finding known as pleural separation, where here's the chest wall, but the lung markings end here at the tips of all these black arrows. Pleural separation tells you that there's something wrong in the pleural space. It could be fluid, it could be a mass, it could be inflammatory tissue, but there's something that's in the pleural space and needs further evaluation. Now, some pleural effusions are quite obvious. When you have a free-flowing effusion and the patient is in an upright position, that fluid is going to form a column. And what you will see is a very dense, homogeneous opacity that obscures the hemidiaphragm on that side, obscures part or all of the heart border, depending on how large the effusion is. And because you have a column of fluid, you're typically going to see what's referred to as the meniscus sign, as the opacity tracks its way up the chest wall and up the mediastinum. Okay. That's an obvious pleural effusion. This patient also has blunting of the left costophrenous angle here, also highly suggestive of a pleural effusion. But there are some less common appearances of pleural effusion about which you need to be aware of. So when a patient is in the upright position, that fluid is going to form a column in the chest. But when the patient lays supine, the fluid is going to layer behind the lung. And so when you're taking the X-ray beam is passing through lung that's sitting on top of fluid, and the film is going to make those things look as if they're one. So the way you recognize that you have a pleural effusion So if the patient's supine, if you see haziness of the entire hemithorax, but you can still recognize lung markings through that haziness as you see here, that's highly suggestive of the fact that this patient has an effusion. How could you confirm that? Well, you could sit the patient up if you're able to do that. You could try to do decubitus films, or you could do chest ultrasound. Now, it gets a little more confusing when patients aren't in the supine position, but are in the semi-upright position. And this is a phenomenon that you're going to see happen in the intensive care unit quite a bit. In these situations, rather than having haziness of the entire hemithorax, what you tend to get is a gradient of opacity. So there's more, when they're in the semi-upright position, there's more fluid at the base of the lung. So it's more opacified down here, but as you move towards the top of the chest, it gets less and less opacified, and you see more lucency in this area. To give you a nice demonstration of how this was in fact pleural fluid here as the cause of this gradient of opacity, this patient had a chest tube placed, and here you can see what the hemithorax looked like after drainage of a significant quantity of fluid. And they clearly had some abnormality in the lung beneath that effusion, but here the gradient of opacity is indicative of an effusion. And then finally, some other less common appearances that are worth being aware of. Occasionally, fluid becomes loculated, so it's no longer free-flowing. This can happen with parapneumonic effusions that convert into empyema, or any other time you have infected pleural spaces. So here you see an example of pleural separation. The lung markings stop at this location, whereas the chest wall is out here. And so you've got fluid trapped up or loculated against the chest wall. This is a situation which this is pretty convincing here for the presence of fluid. It's a very dense, homogeneous opacity that obscures the hemidiaphragm. So you'd be thinking that's probably fluid. But rather than seeing a meniscus, you actually have a flat line here. And this the rest of the hemithorax actually looks quite lucent compared to the left side of the chest where you see normal lung markings. So when you see lucency like this, and a dense homogeneous opacity with a flat line separating the two, that's highly suggestive of the fact that you have both water or some type of fluid and air in the chest cavity. That's known as a hydropneumothorax. And probably in your best interest to obtain some further chest imaging before you go stick a chest tube in there in order to help try to clarify what the cause of this pathology is. All right, we're going to move on to another case. Before I do that, let me stop there again and see if anyone has any questions. Okay. So you've got a 65-year-old male patient who's admitted for evaluation of chest pain. His electrocardiogram and serial cardiac enzymes are negative. You're called to see him at night because he's having more chest pain. He's got an oxygen saturation of 92% breathing air, and you review the chest radiograph that was performed in the ED, and here's what you find. Give you a second to look over that film. So here's the question for you. You've reviewed the film and evaluated the patient. What do you do next? Are you going to give him some intravenous furosemide, start intravenous levofloxacin, order a stat echocardiogram, order a CT aortogram, or order a CT pulmonary angiogram?
All right, I see answers coming in fast and furious here, which is always exciting. I'm gonna give this another 10 or 15 seconds or so. All right. I'm going to go ahead and end the poll here and share the results.
So most people went for the correct answer here is that this patient needs a CT aortogram. I'll take you through why that is the case. If you work with me enough over time, you'll learn that I think that we way order CT pulmonary angiogram. So a useful rule of thumb is if I'm ever giving you a talk and CT pulmonary angiogram is an answer choice in a multiple choice question, don't go for it because it's usually some other answer. But so what's going on in this film? There's clearly a lot of opacity in the hilar region of this patient's chest. And you might certainly think about pulmonary edema in someone who's got a history of heart disease is recognized by the fact that there's sternal wires in this film. Now, sometimes when you look at films, you're going to see some lines and shadows that don't quite make sense. And it's hard to figure out what they represent. And I think a useful rule of thumb is when you see a line and you're not sure what it is, follow it around and see where it goes. Because if you see what it connects up to, sometimes it's helped you figure out what that structure is and maybe provide some clues to the pathology. So here I see this abnormal bulge in this part of the patient's chest. And could it be pulmonary edema? Could it be a mass? I'm not really sure. But as I follow the edge of that opacity around, I see that it kind of comes back in towards the medial, towards the medial portion of the patient's chest and links up here with what looks like the descending aorta. As you follow it towards more cephalad, it tends to meet up here with the patient's aortic notch. So all of a sudden, if you follow those lines around, you start to think, boy, maybe this is the aorta. And would be an abnormal position, an abnormal size of the aorta. I got to do some further assessment for aortic pathology. So we're going to finish up today by talking about some radiographs that you can see in patients with chest pain due to various causes that you don't want to miss. Okay? The first thing we're going to talk about is aortic pathology. Now, in terms of what you want to see for a normal aorta on a film, is you should see the aortic arch to the left side of the patient's midline, and it shouldn't be too prominent. It should be about the size of a quarter, maybe a $50 on the patient's film. That's a $50 coin. And then the aorta should follow a relatively straight course down into the patient's abdomen. Occasionally in elderly individuals, particularly those with long-standing hypertension, you can get what's called an ectatic aorta, in which it will kind of swing out a little bit, but still is of normal diameter. Now that's in contrast to the very abnormal aortic shadows that you see here, where this patient has a huge aortic knob, and in dilation and an awkward course of the descending aorta here, this patient ended up having an aneurysm. And here you see a very large aortic knob and an overall extremely large vessel heading down into the lower chest. This patient had a dissection. Now, if you just look at the film itself, it can be difficult sometimes to say this is an aneurysm alone versus a dissection. You need history to help you. And dissections usually have a very characteristic presentation with sudden onset of a sharp searing or stabbing chest pain going back through the middle of the chest, through the shoulder blades. But in the end, if history and the plain chest radiograph don't help, you're going to move on to a CT aortogram, which will allow you to easily distinguish between these two entities. So here's a patient who has chest pain 3 days after a fall. Take a look at the film, and you can throw some answers in the chat as to what you think might be going on with this patient. Ruth has volunteered an answer. Any other thoughts? Ruth, I think you're correct in that the hilum's looking a little bit on the big side in this patient. You have to account for the fact that it's an AP film and the patient's in the supine position, which will make the mediastinal structures and the hilar structures sometimes look a little bigger than normal. This patient has a subtle but very, very important finding. One of the parts of a systematic evaluation of a patient's chest film is to look at the soft tissue, not just to assess the volume of soft tissue, but also to look for abnormal lucency within the soft tissue. Soft tissue should always look dense and homogeneous and white, like you see here in these upper portions of this patient's left chest and the right chest. But if you look here, you'll see there are these strips of lucency here that have developed. And in following trauma, if you see subcutaneous air and there's been no penetration of the chest wall, so for example, no knife wound, no gunshot wound, no placement of a chest tube, no attempt at a thoracentesis on that side, the presence of subcutaneous air in the absence of any penetrating injury or procedure of the chest wall tells you this patient has a pneumothorax or pneumomediastinum until proven otherwise. So you would think about doing a further chest imaging on this patient to look for evidence of injury, and that would be a non-contrast chest CT. So this is a patient who has back pain, dyspnea, fever, and cough for 3 days in duration. The question is, can you identify anything on the chest film that would account for those symptoms? If you have any thoughts, you can put them in the chat. All right. So a couple of thoughts. Elena is wondering about the fluffy opacities in the lung parenchyma. I think that's a good thought, Elena. I think in this case, it's maybe reflective of the penetration in this film and the technique that makes the lungs look a little more opacified than in some of the other films that we've seen. So I think the bulk of the lung parenchyma is fine. Cardiac silhouette in this patient, I think accounting for the fact that it's a portable film is probably okay in this situation. Remember, portable or AP films will make the heart look a little bit bigger than normal. I didn't specify in this film that it was AP, but it is in fact an AP film. So it turns out when this patient was initially evaluated, people couldn't identify a cause of these symptoms on the film itself. And so a chest CT was obtained and actually showed a very, very dense retrocardiac opacity. So this patient had pneumonia. That pneumonia was abutting the pleural surface, and that's why they ended up having pain in the back of their chest. Okay? So one of the reasons I like to show this case is when you look at a chest film, it is very, very important for you to look at the retrocardiac space on that film, because occasionally pathology is lurking there, but if you don't look carefully for it, you won't see it. On the left here, you see an example of what the retrocardiac space should look like. Remember that there is lung behind the heart in the chest. So what you should see is be able to visualize the diaphragm along its entire length as it courses from the lateral portion of the chest into the middle of the chest. You should be able to see the entire aortic stripe as the aorta descends into the abdomen. And you should be able to make out lung markings through that heart shadow. Contrast that to what you see here on the right. Notice that you can no longer see the descending aorta. You no longer see a hemidiaphragm. And this area here through the heart, it's densely opacified, what people often call the ivory heart sign. You don't see lung markings here like you do in this situation. So that's telling you there is some process in the left lower lobe. That could be pneumonia, it could be atelectasis, it could be aspiration. There's something going on there. And you went back to this patient's film, yes, you could see her entire hemidiaphragm, but the descending aorta disappears in this location here. And this area of the heart on the film is much more densely opacified than out here. So her opacity was in fact recognizable on that initial film with a good systematic read of the radiograph. So don't forget to look at that retrocardiac space, particularly when the story is suspicious for pneumonia or your patient's really hypoxemic and you don't see a good obvious explanation. Okay. All right, we've reached 8 o'clock. It's time to bring it home with a couple of take-home messages. As Gabby mentioned earlier, I had a lot of difficult films in today's session. And guess what? That's what radiography is like with patients who are sick in the hospital. And parts of internship are going to be hard. The goal of today's session was to give you some of the tools you need in order to be able to deal with these difficult situations moving forward. And you'll be amazed over the next couple of months and then over the next couple of years, all these skills are going to come together and you're going to nail all these types of situations. So the big take-home message is, if you are unsure of the position of a line or tube, do more to confirm whether that tube is in the right position before removing it. For central venous catheter, that's transducer pressure off the tip of a catheter or get simultaneous blood gases off the catheter and a known arterial location. Remember that some common problems like pleural effusion or pneumothorax can have atypical presentations on chest radiographs. So you may need to do more to confirm the presence or absence of something. Those more things might include bedside ultrasound, repeat imaging with the patient in different positions, or CT scans if you can't clarify things based on the radiograph alone. And then finally, be systematic so that you can pick up on subtle findings. Use all the information available to you in the film in order to put the answer together in your interpretation. And if you're ever unsure after all those things, just talk to the radiologist. They're a great resource for you. Okay, so that brings me to the end. I'm going to wish you the best of luck with the start of internship, and I'll look forward to working with you in the ICU or on the pulmonary consult service here at Harborview. I can take any questions.
There are a couple of questions in the chat, Andy, and I'll just say thank you to everybody. And feel free to send me any questions through email, and I will see you all next week. I'm the speaker. We'll be covering common topic in cross cover. Have a great week, and I'll let Andy take questions from the chat.
Great. So Ruth's question is, would you see the retrocardiac finding on a lateral film? And the answer is yes. It is generally relatively straightforward to identify a retrocardiac opacity on a lateral film. The problem arises when the patient is not safe enough to go and get a PA in lateral film and you're just stuck with a single portable radiograph. That's when you have to really be careful to look at that retrocardiac space. And then Joey asked about resources for practicing chest radiographs. I actually developed a large chest radiograph tutorial several years ago with the help of a former resident. And I can, if you give me a second, I can get the link to that and put it in the chat because it's an online resource. I do believe it's available as part of your residency teaching resources, but I've had trouble locating it. So just give me a second and see if I can find it. And it should all be accessible with your UW-Net ID. And I will put that address right there now. So.
Thanks, Andy. That's super helpful. And again, as a reminder, we'll be posting the slides. We'll also be posting the recording of this talk, slides for folks who are here and want to review the content, and the recording for folks who were unable to be here because of the day off or being post-call. Great to see everyone this morning. Feel free to stay on the line if you have more questions. Otherwise, we'll see you all next week. Enjoy your rotations.